Hello. Let's talk briefly about care of patients with esophageal problems. Some things I want you to take away from this lecture is to identify risk factors for esophageal disease. We're going to talk a lot about lifestyle changes and teaching that can decrease esophageal disease. When we think about what the esophagus does in the body, that should trigger us to think about a patient's nutritional status and how we can evaluate what those problems will be and what we can do about it, because we're also going to talk about prioritizing nursing care and interventions for esophageal disease. We're going to discuss some common pathophysiology, symptoms, complications, etc. for esophageal disease, and then talk briefly about some surgical intervention. So some of the procedures that are going to be discussed are some of the diseases. We have a gastroesophageal reflux disease, or GERD, hiatal hernias, esophageal cancers and tumors, including Barrett's esophagus, esophageal varices, and then surgical repair. Gastroesophageal reflux disease, GERD. Most common upper GI disorder in the United States. Approximately 15 million American people have GERD symptoms every day. Most often it is in middle age and older adults. GERD happens when mucosal damage is caused by reflux or backflow of the stomach acid into the lower esophagus. So we can see on this picture here, a healthy stomach, it's not flowing up this way, it's staying where it belongs. However, with GERD, for whatever reason, there are a lot of causes of this, but for some reason, the sphincter that keeps this closed is allowing that to backflow, and that can cause damage to that lining of the esophagus and cause the symptoms of GERD. So this is a chronic condition that can become serious. When reflux continues to occur and further damages the mucosa, it leads to irritation and inflammation. Reflux is typically prevented in the body because we have this lower esophageal sphincter right here. And at the top, when our food enters, we have our upper esophageal sphincter from our throat. So when either of these, especially that lower one, gets lazy or too relaxed from decreased pressure and peristalsis, we get that reflux and backflow. Some risk factors. Obviously, we have that incompetent lower esophageal sphincter. Patients who are obese, smoke, or have a hiatal hernia, including Helicobacter pylori, can lead to increased risk for GERD. Obesity and hernia contribute to increased intra-abdominal pressure, which helps push that stomach contents back up through that lower esophageal sphincter instead of allowing it to remain closed. Eventually, this reflux leads to irritation and inflammation and can lead to ulcers in the esophagus and cause some bleeding, and that's problematic. Things like eating large meals can also put that added pressure on there. That's why when you eat too much, you feel that burning pain down there. That is from GERD. And then, of course, certain foods, medications, and alcohol intake can also do this. Some health promotion we can do for GERD. Patients can be asymptomatic and never know, and this is most often cared for in the community setting. Very often are people hospitalized just for GERD unless there's complications. Most often, lifestyle changes can reduce or eliminate this problem, and surgery is rarely needed. So some tips we can give our patients: eat healthy. Limit your intake of fried, fatty, and spicy foods, because that spicy food will get you every time. Decreasing caffeine. Caffeine is a big irritant of the GI system. So all of that beautiful black coffee that we all love to drink, or if you like to drink it with half milk, half sugar too, you can do that. But either way, that caffeine can irritate the lining of the esophagus even when there is no other issues with the GI system. Another thing we can tell our patients to do is to sit upright for 1 to 2 hours after eating before they lay down, and that can diminish their chances of getting heartburn. Some signs and symptoms. Most common, we have dyspepsia, which is indigestion, and regurgitation. So this one and this one, it's a terrible star. Those are your most common symptoms associated with this. Indigestion can include abdominal discomfort, feeling uncomfortably full, nausea, and belching. It's not always a serious symptom, so sometimes patients delay seeking treatment. However, Things can worsen when laying down, straining, or bending over. If indigestion pain is severe, it can radiate to the neck, jaw, or back, and that's when patients come into the ER thinking they're having a heart attack when they're just having heartburn. And that's why we have to eliminate MI as a potential cause before assuming it's GI or vice versa. Pain typically occurs 20 minutes to 2 hours after eating. So if you think back to that assessment that we did earlier, and we were talking about it, we talked about how the relationship between abdominal pain, indigestion, nausea, vomiting, how that relationship attributed to the last time they ate or drank anything. Symptoms of GERD occur 20 minutes to 2 hours after eating. Drinking fluids, taking antacids, and sitting up for 1 to 2 hours after meals before laying down can reduce symptoms of GERD. There you go. That's the second time I said that, so you should know that. Regurgitation can increase the risk for aspiration. Eructuation, aka belching, flatulence, gas, which is gas, and bloating after meals are common with indigestion. Chronic GERD leads to dysphagia, which is that difficulty swallowing, and it narrows the esophagus from inflammation, and it can also make people have painful swallowing, not just difficulty swallowing. So this one right here is another important one to remember. They can have coughing, hoarseness, or wheezing at night, epigastric pain. So when we think about our abdomen and we have our 9 regions, epigastric, that one's up here underneath the diaphragm. We can have abdominal pain. We talked about the belching and flatulence, nausea and pyrosis. Pyrosis, fancy name for heart burn. I can't draw. This is supposed to be a fire. It's not a very good fire and flame. There you go. Help you remember. Complications of GERD. We can get esophagitis. This is inflammation of the esophagus, leads to ulcers. It can cause scar tissue formation, stricture, which is narrowing, and dysphagia, that difficulty swallowing. Barrett's esophagus is another very common complication of GERD. The problem is Barrett's esophagus is a precancerous lesion that increases a patient's risk of developing esophageal cancer, and it develops after significant damage from GERD. We can have respiratory complications. So we talked about we can have coughing, wheezing, hoarseness. As that damages the esophagus, it can make you cough. It can cause you to bronchospasm, give you chronic bronchitis, pneumonia, and you could aspirate as well and get aspiration pneumonia when you aspirate stomach acid into the lungs. Dysphagia and odynophagia is difficulty swallowing and painful swallowing. Sorry. And then this occurs because over time we have that narrowing of the esophagus. Dental erosion can also occur from the acid reflux. Your posterior teeth can get rotted, you can get cavities, you can get different types of sores in your mouth. All of that can occur as a complication from GERD. Important to remember those. All right, so management and education. Here are some things we want our patients to do. They should quit smoking, exercise regularly, sit up straight, eat small meals throughout the day, chew food slowly, avoid heartburn triggers, wear loose and comfortable clothing, sleep with your head and shoulders propped up, minimize caffeine and alcohol consumption, and avoid lying down for at least 3 hours after meal. So this one says 3 hours, your book said 1 to 2, whatever it is, we should wait to lie down after we have eaten. So to successfully manage this, we have to make lifestyle modifications. And then our second step would be to add some medications. If these therapies are ineffective, then our third option would be surgery. So first, let me write this down for you. Number 1, number 2, and then number 3, we have surgery. I'm gonna write in cursive, it doesn't click as much on the screen. All right, so lifestyle changes. I did read you what was on this picture here. We're going to eat 4 to 6 small meals a day. We're going to limit or eliminate reflux foods. things that are high in fat. Chocolate can cause reflux, peppermint, spicy foods. We need to reduce acidic beverages, your coffees, teas, colas, red wines, orange juice. All the delicious things in life are acidic, apparently. We're going to eliminate or limit alcohol and tobacco. We should really work to eliminate, not just to minimize. No snacking in the evenings, and you should avoid eating for at least 2 to 3 hours before you go to bed. You should eat slowly and chew your food. Elevate upright 1 to 2 hours after meals. One suggestion doctors often give is elevating the head of bed on 4 to 6 inch blocks. So you can see here they talk about sleeping with your head and shoulders propped up. They even say up to 12 inches if necessary. Do not wear constrictive clothing. That adds pressure where you don't need pressure or want pressure. We want to avoid heavy lifting, straining, and working in a bent over position. We can chew antacids thoroughly and then take a full glass of water after them. Some medications we can take. We can take a proton pump inhibitor, or PPI. These are your things like your Prilosec, your Protonics, your Nexium. They reduce gastric acid secretions and are given in a daily dose. They can also be given IV if needed. An H2 receptor blocker or an H2 receptor antagonist. This is your Pepcid, your Tagamet, your Zantac. Reduce acid and side effects and improve symptoms of GERD and helps to heal some of that damaged tissue, so that's really great. And acids, we have things like Maalox or Mylanta, Tums or Rolates. Take 1 hour before or 2 to 3 hours after meals to avoid any kind of interactions, but those are just some common things. If things don't work, then we would move to surgery, which we're going to talk about a little bit more on a later slide. Hiatal hernias. This is the protrusion of part of the stomach through an opening in the diaphragm. It's most common in older adults and women. There are two kinds. There's a sliding hernia and there is a paraesophageal or a rolling hernia. So sliding occurs at the junction of the stomach, moves up above the diaphragm. So it's this middle picture right here. We can see that this little piece is sticking out, but it's going up into the esophagus. It's not actually popping out into the abdomen. Happens when the patient is supine. When the patient begins standing upright, then it'll slide back into place where it belongs. A rolling hernia, on the other hand, is when the fundus of the stomach rolls up through the diaphragm. So it goes out from the muscular wall. And you can see right here, we get this little piece coming out. So with sliding, it goes up into the esophagus. With a rolling, it actually goes out through the diaphragm. It makes a little pocket. And this type of hernia is more serious because the pocket can be obstructed or strangled, which means that blood flow gets cut off. Some causes and risks. We have structural changes from weakening of the muscles that occur with aging, especially in the diaphragm. There are certain conditions that increase intra-abdominal pressure, things like obesity, pregnancy, ascites, tumors, intense physical activity, or heavy lifting on a continual basis. I know lifters are very careful that they don't get hernias because it is very common. Some symptoms and complications. Hiatal hernias very much mimic the symptoms of GERD, and it can actually lead to a patient developing GERD and getting those same complications as what a patient with GERD has. So they're even treated very similar. We can have esophagitis, that inflammation of the esophagus. We can get a hemorrhage from an ulcer erosion, which is very rare. Stenosis or stricture of the esophagus. We get ulcers in the herniated part of the stomach, strangulation and necrosis in that hernia, and then regurgitation with tracheal aspiration, and they actually aspirate into the lungs. Again, that's severe. Most people I know with hiatal hernias, really, they're not that serious for them. They're uncomfortable, but they manage, they can live with it. They just have to eat a little bit slower. When we look at management and education for hiatal hernias, this is going to be very similar to what we're doing for GERD. We're going to do some of the same medications, some of the same management, and of course we're going to reduce abdominal pressure because when you have that upper hiatal hernia in that epigastric area, any added pressure is very uncomfortable, although most people don't wear clothes that are tight right there. You never know what you're going to find. So some ways we can do that are to remove restrictive clothing and avoiding lifting or straining. And the number one way that we can fix this is through surgery. So we can do things like a herniotomy, which is the removal of the hernia sac. It works great for a rolling hernia. We could do a herniorrhaphy, which closes the defect. That would also be great for a rolling hiatal hernia, because then we could repair that damage that's in the wall of the diaphragm. A fundoplication is a very popular one. It's a portion of the stomach being wrapped around the lower esophagus and helps to anchor and reinforce that lower esophageal sphincter. So you can see this picture here, it kind of makes a little pocket and just helps strengthen that. And then we can do a gastropexy and attach the stomach below the diaphragm to prevent reherniation. I don't know how common that one is. I'm most familiar with the herniotomy or a fundoplication in this instance. Esophageal cancers are not that common, but they are very serious. They occur in the middle or lower portions of the esophagus, and they're most commonly adenocarcinomas. Typically, they are malignant with metastasis. The tumor appears as an ulcerated lesion that can penetrate into that muscular layer and extend beyond the wall of the esophagus. Because there is a lot of rich lymph and blood supply into the esophagus, when that tumor spreads, it spreads through the lymph nodes and metastasizes or mets through the whole body. Most common sites for mets from esophageal cancer is the liver and the lungs. By the time the patient is diagnosed with this disease, it is often very advanced because symptoms don't develop until late. They don't know that they have it, and you're going to find that's very common with a lot of these cancers we're going to talk about with their GI lectures. Some risk factors. We have Barrett's esophagus, which we did talk about a little bit already. We have smoking, excess alcohol use, obesity, and occupational exposure to chemicals. Some symptoms we are going to see when they start to show. The most common feature are persistent and progressive dysphagia. Most common, right there. It'll start with things like meat. They start to choke on that, then eventually start to choke on soft foods, and then they choke on liquids. They get that feeling of food sticking in their throat, painful swallowing, regurgitation, and it just keeps getting worse. Pain happens at a later time or a later stage of the cancer. Usually it's substernal and epigastric abdominal pain that's severe and persistent, and pain worsens when they swallow. When a patient has esophageal cancer and they have that abdominal pain, it can also radiate to the neck, the ears, the jaw, and the shoulders. It can cause sore throat, choking, and hoarseness. We see symptoms like anorexia, nausea, vomiting, and weight loss of more than 20 pounds. We see changes in bowel habits. They have diarrhea, they might have constipation, they might have bleeding. All these things are just different than what they've been experiencing. The number one complication we can have with esophageal cancer is hemorrhage that can occur when the cancer erodes through the esophageal wall into the aorta. If you think about where the esophagus is located and where we would have that aorta and how big that aorta is running through the abdominal, like we talked about in cardiovascular, it's not that hard to believe that this could happen. So instead of having a ruptured aortic aneurysm, now you have a cancerous ulcer that eroded from the esophagus through the wall of the aorta, and it's still bleeding like it had ruptured from an aortic aneurysm. And we know from previous lectures that's a medical emergency. Some diagnostic studies we're going to do. We're going to do a biopsy via an EGD. That EGD is that esophogastro It's the scope through the mouth, the bronchoscopy, etc., except they go through the top to see the stomach. We can also do an ultrasound. They like to do barium swallows with the cancer, and of course PET scans, because if a patient has cancer cells and they get a PET scan, those will light up significantly and show what kind of cancer and where it's located. Maybe not what kind, but at least where it's located and how much there is. Management. Our primary concern is weight loss secondary to that dysphagia. So we need to maintain adequate nutrition intake and weight. So let me write this down for you. Weight loss secondary to dysphagia equals number one concern. Beautiful. Okay, so we need to help with this nutrition therapy by preventing malnourishment. We're going to administer foods and fluids to support the patient. We're going to have a dietitian work on the caloric needs. We're going to position that patient upright, help them eat slow. We're going to meet their dietary needs through either a regular diet, if they need a mechanical soft diet, ground, puree, etc., so that they can get that food that they need. We might even see patients that start to have our enteral feedings through the feeding tubes. Probably not an OG at this point. It would probably be surgically put into the body, like a peg tube or a Mickey button tube. We want to have a speech language pathologist or an SLP perform swallowing therapy and do swallow tests, make sure they're not going to choke on things. We're going to do chemo and radiation to treat cancer, and we might do a type of therapy called esophageal dilation, which provides relief of dysphagia and helps to widen that esophagus that's narrowed. We can also do some surgical management to remove all or part of the esophagus or parts of the esophagus or stomach, and thus help treat the cancer and remove tumors. Esophageal varices. This is a complication of a lot of disease. It really doesn't ever occur on its own. It has to have a reason. This is a secondary cause of something. So you can see here causes is portal hypertension secondary to cirrhosis. We're going to talk about that a little bit more later on. But portal hypertension is elevated blood pressure in veins that carry blood from intestines to the liver. So it's all of this. Over here, we have our portal veins. You can see this from the liver. This is where that hypertension is occurring. It's putting all that pressure on that little vascular system right there that the liver has, because the liver is very highly vascular, and it's causing a lot of damage. So this impairs the circulation of blood through the liver, and varices develop when the blood cannot properly circulate. Varices, we can see here, it's little bumps, and I don't want to call them holes because they're not necessarily holes, but it's changes to the lining of the esophageal wall. But it's kind of, how can I describe this? It's kind of like a varicose vein in your leg, except it's inside of your esophagus. So they kind of get puffed up like that, and those veins are very, very thin and fragile and can bleed very easily. Older adults have a depressed immune function, decreased liver function, and cardiac issues, so that makes them more vulnerable to this disorder, particularly when they start to bleed. If these bleed or hemorrhage, it is a severe medical emergency with a high mortality rate. So we talked about the portal hypertension a little bit, alcoholic cirrhosis, patients that get viral hepatitis, and being older are all things that can cause this. I have seen just a few cases of this. It's not as common as we would think, but I've also seen several patients that have had severe alcoholic cirrhosis or viral hepatitis to where they are jaundiced and have all kinds of symptoms. They have really bad ascites, and eventually they just die because their body can't handle all those toxins built up in the blood anymore. But the esophageal varices, really, really bad. If the patient is bleeding, they have to intervene immediately and give them blood and stop that bleeding somehow, usually with a procedure, or that patient has a high chance of dying from hypovolemic hemorrhagic shock. Okay, so signs and symptoms. They are asymptomatic until those varices begin to bleed. So if they have some of those risk factors, like the portal hypertension, or they have cirrhosis, or hepatitis, or they're old, they're not necessarily going to know they have these because they are asymptomatic. And then they're going to start to bleed. Then we're going to get that hematemesis. We're going to get the melena. So hematemesis, if you remember, that is bloody vomit. Melena is bloody stool. It's usually really thick bloody stool. It's not always that black I mean, it'll be black, but it's not always black and thick. Sometimes it's really kind of weird. It stinks really, really bad. You can always smell when a patient has a GI bleed. We start to see deterioration of their physical and mental status, and they go into shock quickly. Not surprising, they are hemorrhaging and they're going into hypovolemic shock because they're losing that blood volume and it's going into their body, it's going out, they might be vomiting blood, they might be pooping it out, it's maybe coming to their eyes, I don't know. They get tachycardic as that body's trying to compensate for that hypovolemic shock. They get really cool, clammy skin. So when bleeding occurs, it can happen from doing something like the Valsalva maneuver, so straining when you're pooping. It can happen from lifting heavy objects. Coughing or sneezing too hard can make a person with an esophageal varices bleed and hemorrhage. And consuming alcohol. Alcohol is a blood thinner, it can rupture them right open. Diagnostic tests, we need to do liver function tests, hemoglobin and hematocrit levels, and we need to see if they have elevated ammonia levels, because I'm going to connect some dots for you here. We can come back to this. Elevated ammonia means there's toxins because they have a broken liver, and broken liver usually means cirrhosis. And we can also do an endoscopy and see where those varices are and see if we can do anything about it. Management. We're going to give medications. We should be familiar with propranolol at this point. We use it to decrease heart rate and hypertension. This is used prophylactically, so we want it to reduce that portal hypertension. It's not going to work in an emergency. That's too late. So if they have cirrhosis or they have hepatitis and they're at risk for portal hypertension or they have regular hypertension, we need to start them on propranolol to help get rid of that. Octreotide, we talked about in endocrine, is a synthetic form of growth hormone. It decreases bleeding associated with esophageal varices. I don't really know the whole mechanism of why, but I do know it doesn't stop the blood pressure, it just stops the bleeding. The blood pressure will still stay really, really high, which is bad. We also have vasopressin, or antidiuretic hormone, causes constriction, which reduces the pressure, doesn't stop the bleeding. Another procedure we can do is something called an endoscopic variceal ligation or banding therapy. It's used to treat acute bleeding. They're rubber banded off to cut off the circulation. That causes them to necrose or die and they slough off. And it helps to re-heal after the fact and decreases the risk for re-bleeding post-operatively and reduces their mortality rate, which is great. Another procedure is called the TIPS. This one I've heard of. I'm not very familiar with it, but it has to do with putting a catheter into the portal veins to stop the bleeding. It blocks it all off. Very, very risky. It's also very expensive and dangerous. So they only do a TIPS procedure if those medications aren't working and if that banding therapy has not worked. But the banding is kind of cool because it's literally like putting a rubber band on it, and that's why they call it banding. All right, that's all I have for you on this lecture. Let me know if you have any questions. Thank you.